Welcome to our live webcast, Neuromodulation, Neuraxial and Peripheral. Thank you for joining us tonight. My name is René Prescora. I'm practicing at the University of Florida in Gainesville. I'm the program director there, and I will be serving as moderator of this webinar. I do not have any disclosures to the topics presented today. I'm also very proud that I'll be joined by our speakers, Drs. Maurice Caparo, Bhavna Yalamuro, and Kiran Patel. Dr. Caparo is the Associate Program Director of the Multidisciplinary Pain Medicine Fellowship at the Montefiore Medical Center. Dr. Yalamuro is the Assistant Professor at the University of Virginia, Department of Anesthesiology and the Pain Medicine Division. Dr. Kiran Patel is the Director of Pain Medicine at Lenox Hill Hospital in New York, and she is the Program Director of the Pain Medicine Fellowship Program of the Hofstra Northwell University. Again, thank you very much for joining us, and I think we will start this evening with our first presentation presented by Dr. Caparo, and he will talk about neuromodulation, neuraxial and peripheral as an introduction.
Hello, everyone, and thank you for having me. Again, I'm Dr. Maurice Caparo. I hope everyone had a happy new year. I'm here to present just the introduction regarding this very near and dear topic to all of us, neuromodulation and its use in chronic pain. As pain physicians, we are well aware that chronic pain is a very significant issue, and we want to treat it in the best way that we can. And neuromodulation is simply one of those tools that we can use to really assist our patients in improving their quality of life. I have no disclosures. So I wanted to start by a simple definition. What is neuromodulation? And you can see on the screen the definition as defined by the International Neuromodulation Society. But in simple terms, neuromodulation is a technology that acts directly upon nerves. It is the alteration or modulation of a nerve by delivering electrical, magnetic, or pharmaceutical agents directly to a target area. Now, neuromodulation as a whole, it is a broad range of different techniques, whether non-invasive like transcranial magnetic stimulation, or more implanted devices like spinal cord stimulation or even deep brain stimulation. The focus today will be primarily on neuromodulation in the setting of spinal cord stimulation, neuraxial stimulation, and peripheral nerve stimulation. This is a simple overview of the nociceptive pathways of pain. Hopefully, most of us are familiar with this. Starting from the bottom right, you can see that you have a noxious stimulus, and then you have the phenomena of transduction, which is the conversion of a noxious stimulus into electrical energy. After that, through the A delta and C fibers, which are our primary afferent neurons, you have the phenomena of transmission, by which the impulse is transmitted right to the spinal cord. Then you have the effect of modulation, which you can either modulate the signals up or down. And it can occur, of course, at the spinal cord, but it can also occur at different sites throughout the central nervous system. After modulation, you have the act of perception, which is how a patient will perceive pain. And this is not only nociception, but it's, of course, the affective component of pain. And one of the things that I like to emphasize is that pain is always biopsychosocial. You always want to treat the patient as a whole human. And of course, you want to treat anxiety, depression, other medical comorbidities on top of the things that we can offer as well. Now, to the topic of neuromodulation itself, it is certainly not a novel idea. It has been described as early as the year 15 AD by Scriboni Largi, who was a physician on the Roman Empire. He actually discovered, incidentally, that by stepping on a torpedo fish, which is pictured on the right, you would actually have significant relief from gout pain. So that was actually one of the first documented cases of active neuromodulation with a medical use. Several centuries later, you have the Italian physician Luigi Galvani, who discovered that the muscles of the frog's legs actually twitched when they were struck by an electrical spark. And this actually was one of the earlier studies in the use of bioelectricity. A century later, a neurosurgeon by the name of Victor Horsley in the UK, he actually used neuromodulation more diagnostically to find foci of epileptic foci. And then after finding those foci, he would actually resect those areas from the brain to help with intractable seizures. And of course, I believe most of us are familiar with the gate control theory. This was published in 1965 by Melzek and Wall. And as we know, essentially by activating these larger fibers, which we now know as A beta fibers, you're actually diminishing the effect of the C and alpha delta fibers. Shortly after, actually, 2 years later, Wall and Sweet developed the first actually medical use of neuromodulation. And what they did in their study, they actually stimulated different peripheral nerves. One of them was the supraorbital nerve, to see if this could help with their pain. And actually, they discovered that for many patients, it was very, very effective. The same year, a physician by the name of Sheely in Wisconsin, he was the first physician who did the first use of spinal cord stimulation. And it was a very rudimentary device. It was actually a single lead device, which was actually implanted and sutured into the dura, and it's provided dorsal column stimulation. The patient was a patient with metastatic cancer who was having significant chronic pain. After the device was implanted, they actually noted that the patient did have significant improvement of his pain, although he did die shortly after. One of the interesting things about this case report was that the patient, while they were feeling the stimulation, they actually did not have any changes in sensation when they were being tested. And since then, a lot of things have significantly improved. Of course, we now have modern devices, the invention of the pulse generator in the late 60s, 70s. And now we have several devices in different companies who are able to offer this technology. Now, in terms of spinal cord and dorsal root ganglion stimulation, as you can see in the graphic to your right, the primary use typically is in the dorsal columns, but more recent waveforms have actually also helped with the dorsal horn stimulation. In terms of anatomical targets, you also have the DRG, and you can also do a DRG stimulation. This can be particularly helpful if you need to stimulate a particular dermatome, such as in shingles, for example, whereas spinal cord stimulation at the dorsal horns and the columns affects a more broad region. A recent study a few years ago showed that DRG tends to have less lead migration, so that could be an advantage to DRG, although the indications are overlapping. You can, and I will discuss this a little bit later in my slides. Some of the things to keep in mind in terms of neuromodulation is the parameters of stimulation. So what are you actually doing when you're delivering that electricity? So first of all is voltage, which is essentially a potential difference between a pair of electrodes. And my analogy is, think of it as a waterfall. The voltage will be the difference between point A and the top of the waterfall and point B. That's the potential energy that is stored. The current is essentially the waterfall itself, which is the electric charge, which is traveling through the tissue. Pulse width is actually the voltage which is applied between the electrodes for a defined length of time. And amplitude is essentially the current under constant current mode, but it could also be the voltage under a constant voltage mode. The frequency, which is also something that could be modified, is how many pulses are applied within a length of time. So by modifying these parameters, you can come up with a myriad of different waveforms, and I will name some of these in the next slide. Tonic is essentially the basic simulation waveform that you can have, where the patient does have a paresthesias coverage. You can also have high frequency and bursts, and again, a multitude of different waveforms that you can have. Some of these are proprietary, and some of these have different mechanism of actions and different neuronal targets. This is a recent study that was published by my colleague, Dr. Wahizi at Montefiore, which essentially summarizes a lot of the different mechanisms. And as you can see, different waveforms have different targets. Sometimes it is the dorsal horn or the dorsal column, as well as glial cells. And these are the different mechanisms of action. Besides the gate control theory, you can also have different proposed mechanisms at the level of the spinal cord. Some studies that were done on animals showed release of GABA in the dorsal horn. Also, there is antagonism of the NMDA receptor, as well as different attenuation of nociceptive reflexes within the spinal cord. And then other proposed mechanisms are suprasegmental at the level of the brain, such as the main areas in terms of pain transmission, like the locus coeruleus and the nucleus wrap. And of course, many of these neurotransmitters, including serotonin and norepinephrine, are very important in the inhibiting pathways of pain. Interestingly, one of the animal studies did show that tonic spinal cord stimulation of the dorsal column actually reduced allodynia and hypersensitivity, even after a part of the dorsal column was transected. Similar to the brain having a homunculus, you can have a somatotropic arrangement in the spinal cord. And as you can see here, there are different areas where you can target specific anatomical parts of the body, which are listed down here. Now going into indications, a lot of the indications have a lot to do with failed back surgery syndromes or patients who have continuous pain despite undergoing surgery or multiple different kinds of treatments, such as post-laminectomy syndrome. Other potential uses or indications for neuromodulation include CRPS. One of the more recent indication is painful diabetic neuropathy, primarily with high frequency and other devices. And briefly just touching base on potential complications of spinal cord stimulation. They can be divided into two different categories. They can be hardware related or they can be biological. Hardware related is actually one of the more common complications of spinal cord stimulation, and this is actually a board relevant question. One of the more common hardware related complications is lead migration. Less common lead fracture or malfunction, as well as battery failure. Now, in terms of biological complication, they're very rare, but they do range some of the higher percentages here from older studies, but you can have pain related to the components or a seroma formation, which can cause pain and discomfort as well. You could have potential wound infection, as with any other procedure that you're doing. Most of the wound infections in spinal cord stimulation were actually superficial. They were not deep, thankfully. Skin erosion, dural puncture, a lot less common. And of course, neurological injury is extremely, extremely uncommon. Something like a hematoma is highly unlikely. Moving on to peripheral nerve stimulation. This also goes along the theme of the gate control theory, but you're also actually focusing on a specific nerve or a specific field of the nerve, which innervates a specifically painful region. Back in the day, peripheral nerve stimulation was not as popular, primarily because there were a lot of complications in terms of lead migration or dislodgement. As you can see, when a device is attached somewhat peripherally, there can be a lot more risk for migration. However, nowadays, the technology has significantly improved and the use has increased. Again, you can have peripheral mechanisms for PNS and also central mechanisms. One of the proposed mechanisms in terms of animal studies, you can see that you can have excitation failure of Al, A, and C fibers. You can also modulate the biochemistry of the local microenvironment. In terms of central mechanisms at the level of neurotransmitter, such as serotonin or GABA, is being affected as well. You can have increased inhibition of the dorsal or wide dynamic range neurons. And these are some of the indications where you can use peripheral nerve or peripheral nerve field stimulation, commonly used in headache disorders such as migraines. If you have a specific motoneuropathy, there's a lot of different targets where you can assist the patient in their nerve pain. Sometimes joint pain, such as knee or shoulder pain, can be improved with peripheral nerve stimulation. For example, in the shoulder, you can do an axillary PNS versus a suprascapular. Pelvic pain, lower back pain, other common indications, including post-amputation pain. Complications for PNS, very similar compared to spinal cord stimulation and DRG stimulation. They can also be hardware related or biological. Again, the fact that PNS devices tend to be smaller, typically there are less complications, but one of the more significant complications still is lead migration. In summary, as I discussed before, neuromodulation can be beneficial, and it can be one of the tools that we can use to improve our patients' quality of life and improve their pain. In selected populations, of course, because we all know that patient selection is very key when it comes to treating our patients. And again, you always want to take care of the patient as a whole. You want to think about other comorbidities, other potential pain generators. All in all, it does have a low morbidity rate, especially now that the technology has improved exponentially. It is something that you can use in combination with more conservative therapies such as physical therapy, including medications, of course, and behavioral therapy. DRG, again, could be more useful if you want to target a specific dermatome. PNS if you want to target a particular peripheral nerve. And of course, we still need more studies to discuss the continued efficacy of neuromodulation in the long term. Now, any questions?
Maurice, thank you very much for the presentation. I think for the flow of our evening, we're going to save all the questions for the end of all three presentations. And I do suggest for the audience to use the Q&A feature on the bottom of your screen, and you can either place it with your name or not, and put in your question. And at the end, we will find the most appropriate speaker, team member to answer your question. So feel free, go ahead. Like I said, there are no stupid question. And thank again, Dr. Caparo from New York, and I'm happy to introduce Dr. Bhavna Yalamuro from the University of Virginia, and she will be talking about peripheral nerve stimulation. Bhavna, welcome to the floor.
Thank you, Renee. Hi, I'm going to be talking about peripheral nerve stimulation today. Liz, can you move on to the next slide, please? Next one. So I'll be briefly talking about the different types of stimulators on the market, because they're slightly different from spinal cord stimulators that are available, which function fairly similarly with variations in waveforms in terms of the parts. I'll give you a brief overview of the approach, because each of these approaches to placing peripheral nerve stimulators is extremely dependent on what your target nerve is. And we'll go over the outcomes of peripheral nerve stimulation. Next slide, please. So there are basically two categories of peripheral nerve stimulators: temporary devices, which are in for 60 days, and that is the duration of therapy, which is, most of you might be aware, SPR Therapeutics or Sprint. And the permanent ones are on the market are StimRouter by Bioventus and Nalu Medical, which are commonly used. There used to be another manufacturer who's now fallen out of favor. And we will kind of discuss in the next couple of slides what the differences in each of these are. Next slide, please. So with Sprint, it's a lead which is placed internally with an external connection that comes out. It's not completely tunneled under the skin. The lead has a helical configuration and has a waterproof bandage that you wear over the lead when it's connected to the EPG and the battery. And for this device, a minimum of 2 centimeters of the lead should be implanted under the skin to minimize migration risk. The length of the lead in the introducer itself is about 12 centimeters, and it allows fairly significant amount of flexibility in how far from the target site that you want to start it. These leads are unique in that because of the helical configuration, there's a very low risk of infection. Which the risk is very, very low in comparison if you were to leave a permanent nerve catheter in, for instance. Next slide, please. So this is a picture of the StimRouter system, which has the lead on top with the external pulse generator and battery on a pad that snaps on the skin that you place over these leads. You have a little remote control that the patient can use to use any of the 8 waveforms that they have. And the ideal distance between the receiver end and the electrode end, which has the 3 marks on top here, should be about 7.5 centimeters for there to be effective functioning. You can have the entire 15 centimeters between them if you want to, but if it's about 7.5 and you can create a nice electrical arc between the two and place the EPG between that, you often can use very low energies and have good stimulation. And this device can be placed either under fluoroscopic guidance, depending on the target site, or ultrasound guidance. Next slide, please. The third one that's on the market is slightly different from the two in that this is a permanently implanted device, but it has an implantable pulse generator that is placed under the skin. It's not connected. It's not a wireless technology that's outside, or nor is it connected. Not is it placed outside the skin. It's completely, even the pulse generator is under the patient's skin. There is a therapy disc that the patient will wear over it. And it's also slightly bigger than the other systems in terms of lead length. The other unique feature about this pulse generator is that it has a battery life of 18 years. So it should minimize the need for replacements. The other unique system about this therapy is, or this manufacturer, is that they also have a trial system that you can implant for 30 days and trial, unlike the other two, which don't have a trial lead or a trial process that the manufacturer offers. Next slide, please. So this is just a brief overview of what the differences are. If you look at the lead size, the SPR leads are probably the smallest. In terms of length, also they're smaller than the other leads. The Nalu leads are probably the longest. There's a difference in their frequency and the amplitudes that you can offer the patients. The Sprint lead just has an uninsulated tip, whereas both the permanent systems offered by BioVentus and Nalu have electrodes and allow for different programming capabilities. Next slide, please. So when you're considering placing these devices, it's also important to consider the patient's need for MRIs. If you look at Sprint, the lead itself is not compatible. But if you do have a lead fragment that's left when you pull it out after 60 days, that fragment is MRI conditional. So that's an important conversation to have with the patient, and also important in your decision-making process, depending on what your patient's other medical needs may be. Stim router, is permanently implanted. The internal components have the MRI conditionality for 1.5 Tesla and 3 Tesla if the MRI bores over 50 centimeters away from the lead. And for the Nalu system, it's fairly similar. Both the stim router and the Nalu leads are tined leads, which allow for the leads to anchor into the tissue and for fibrous tissue formation and scarring to occur to prevent displacement of the leads. And all these, the MRI compatibility of all these devices is only for the internal components, not for the therapy disc in terms of Nalu, not for the external pulse generator transmitter in terms of stim router. So now that you know what these different leads, what these different devices are on the market, let's also look at what the indications are. Next slide, please. When you look at the current FDA-approved indications, they're for relief of chronic intractable pain and for post-surgical or post-traumatic pain management for back and extremities, only for Sprint Therapeutics. And that's for the 60-day system for like post-traumatic and post-operative pain. For the other devices, it's for severe intractable chronic pain of peripheral nerve origin as an adjunct to other modes of therapy. And none of these are approved to treat pain in the craniofacial region. So off-label uses that you might see in case reports and literature might be for headache, facial pain, pelvic or urogenital pain, chest wall pain, phantom limb pain, and for the stim router system, even back pain is an off-label indication because it's not technically peripheral nerve in origin. What are the conditions that we commonly treat clinically with these devices? It's median radial or ulnar neuropathy, something that you can attribute to a single nerve, like occipital neuralgia, cluneal neuralgia, femoral, sciatic, or obturator neuropathy, neuralgia paresthetica. Also used fairly frequently in practice for post-amputation pain, phantom limb pain, chronic knee pain, post-TKA, post-stroke shoulder pain. And for the Sprint therapeutic device, they have the approval, as I mentioned earlier, for acute post-surgical and chronic axial low back pain. The contraindications, next slide, please. Next slide. Obviously, patient refusal, any allergy to the device components, coagulopathy, or local infection in the site. Next slide. So how do you determine who's a candidate for an implant? One is determining if they have pain corresponding to one or more peripheral nerves that you can target. A psychological assessment of the patient, which is akin to when you place a DRG or spinal cord stimulator, is important. Ability of the patient and caregivers to comprehend and use technology. And the last part is very practitioner and device dependent, because unlike spinal cord stimulation, there's not very clear guidelines on the exact pathway that a patient who's going to have a peripheral nerve stimulator implanted needs to undergo. There's no literature on a trial process or a diagnostic nerve block. One of the device manufacturers, like I mentioned earlier, has a trial system that you can use, and the others don't. And some practitioners in their practice might choose to use a diagnostic nerve block before they choose to implant a device. And others might just choose to move directly to an implant. So a little bit of this is practitioner dependent, and I think more work is being done on this to help determine the ideal pathway to determine candidacy. Next slide. So if you look at this, you can see in yellow that this is just a diagrammatic representation where in the yellow, it's the nerve. Above it, the lead is implanted with the receiver, the electrode end, which is tied closer to the nerve, and the receiver end, which is subcutaneous. So I'm just going to go over the basic principles of implanting these devices, because the approach is going to be very different when you do an axillary or a suprascapular versus doing a genicular or an ilioinguinal. So each of those is going to be very dependent on the ultrasonographic picture for which that you're going to get to place the device. For some of them, you could use fluoroscopy, like for genicular and for suprascapular, and even for the low back, when you're stimulating the medial branch nerves, you can use fluoroscopy. But for a large number of these, especially if you're stimulating the brachial plexus, the sciatic, or the saphenous nerves, good ultrasonography skills become vital. At which point it's fairly akin to how you would with Sprint if you were to do a peripheral nerve block. Next slide, please. Listen, so you identify the area of pain and the likely anatomical target, and you scan the nerve of interest using the ultrasound and plan the trajectory of the implant. For the temporary system, you need at least 2 centimeters of the lead implanted in. So if it's a really superficial nerve, you want to make sure that you start a little more distal to allow enough of the lead to be under the skin to avoid any displacement or movement. And you can plan the trajectory of the implant. For the stem router system, you want to ensure that when you are tunneling the other end of the lead, that you are able to allow at least 7.5 centimeters between the two ends, so that the patient can place the EPT over that area. It's also important to ensure that the lead doesn't cross joint lines. Plan and avoid going through large muscles if you can, because it can lead to uncomfortable stimulation while you're testing, or when the lead is in place too. And for each of these, each of the device manufacturers have instructions on placement for each nerve. So it's important to go through those before you choose to implant. And then for the permanent devices, you secure the lead and tunnel it for an implant. And for the others, for the temporary system, you make sure that it's clipped on and an adhesive bandage is put and you secure it appropriately. When I do place these devices, I do ask patients to be cognizant of their movement and make sure that at least for the first couple of weeks, there's not major jerky movements that they're doing over those areas if possible, to avoid displacement of the leads, because these devices are extremely dependent on their being very close to this target to be able to function properly. Next slide, please. So what are the complications that can occur during the procedure? Pain and discomfort during the procedure can occur. It's not uncommon. There can be infection. There can be lead migration and fractures or displacement of the leads. Allergic dermatitis, because a lot of these require a lot of adhesive bandage on top and have external components to the technology. Stimulation intolerance can also occur. Complications like peripheral nerve injury can occur if you're too close to the nerve and you're stimulating. Oftentimes that can be detected fairly early when you're doing the testing during the implant itself. And there can be localized hematoma formation as well. Next slide. So we're just going to look at outcome data for both chronic and acute pain. I think this neuromodulatory therapy is a little unique in that we do have some data for acute pain as well, and not just for chronic pain. For chronic pain, next slide. It has been used, like I mentioned earlier, and is approved for treatment of pain which is caused due to peripheral nerve etiology when it's refractory to other conservative treatments. However, so far we've had only one high quality study, which gives us level 2 evidence that demonstrates the efficacy of this for peripheral neuropathic pain that's secondary to trauma or surgery. Most of the other literature that we have in the realm of PNS is case reports. And that's partly because there's been a huge resurgence of interest in this technology only over the last couple of years, because though it's been in practice for several years before, like Dr. Kapara mentioned, there are multiple barriers to this being a widespread technology because of the invasiveness of the techniques used in the past and the bulkiness of the leads. Next slide. In terms of CRPS, a lot of the data that we have for PNS and CRPS as well is in the form of case reports or case series. The quality of most of these studies is fairly limited, and it does have only a level 4 evidence for PNS in the management of CRPS. However, a lot of practitioners use it fairly early in the algorithm before they move on to spinal cord stimulation or DRG, because of PNS is a little less invasive than those other advanced neuromodulatory techniques. For post-amputation pain, you have a very few high-quality studies again, which provide a level 2 evidence for post-amputation pain. But because post-amputation pain is usually very difficult to treat, PNS can be considered fairly early in the algorithm because we don't have too many therapies that are very effective for it. Next slide, please. So for shoulder pain, it was first used on a 58-year-old stroke survivor with chronic shoulder pain. They noticed a significant reduction in pain over the shoulder, improved passive range of motion, motor function. And since then, we've had multiple case reports on PNS for hemiplegic shoulder pain, subacromial impingement, and adhesive shoulder capsulitis. And all in all, when you look at all the data, there was another RCT with 25 patients with chronic shoulder pain, where they only did 3 weeks of PNS versus usual care and noted a significantly improved pain reduction in the PNS group. In a review article, they concluded that that was level 2 evidence for PNS to treat shoulder pain. But I will point out that the duration that this RCT noted was an extremely short duration, like 3 weeks is not very big in the realm, considering the patients that we treat who've had pain for several years. Moving on to the next slide, we'll look at some data for pain, for low back pain. One of the first reports was by Verrills et al. He looked at a case series with 14 patients, noted a significant reduction in back pain with peripheral nerve stimulation. This was back in 2009. Subsequently, Dabe et al. In 2019 published an RCT with 116 patients. 56 were in the PNS group, 60 were in the conventional medical management group. And the PNS group had a significant pain reduction in mean scores, and they found it was more effective than conventional medical management. More recently, or pretty much around the same time, Cohen et al. Published a case series with 9 patients, of which over 83% had a 50% reduction in opioid and non-opioid medication use, lasting about 7 months. So it's most of the more recent data on PNS for low back pain has been using the 60-day system. Moving on, we're just going to look at some of the evidence for acute pain, and we're going to see if it really works for acute pain or not. So a lot of the work on acute pain, next slide, please, has been published by Dr. Ilfeld and group, and they published a feasibility study initially for patients undergoing TKAs, and looked at 5 patients with uncontrolled pain post-TKA, and the peripheral nerve stimulator was placed anywhere between day 8 to day 58, and all the patients noted immediate analgesia, significant reduction in resting pain, and then they extended the study later to include more subjects. Next slide, please. And the subsequent study noted that when they looked at the median time to opioid cessation, it was significantly lower. It was only about 6 days in patients who had peripheral nerve stimulation for TKA management. The morphine equivalent dosage was also significantly lower. There was an improved walk distance to almost 126% of the pre-op distance by 12 weeks. And the median time opioid use in the first 90 days post-op was also about a third of what it would have been if just traditional post-operative pain management techniques were used. So a lot of this is promising, especially if any of you are going to be in the realm managing both acute and chronic pain, or dealing with transitional pain once you're in practice. Next slide, please. And this is just graphical representation of some of the same data. Next slide, please. Subsequently, they expanded this to look at the data for PNS with rotator cuff surgery and noted that there was less opioid consumption but in this study, it was slightly different in that it was placed preoperatively versus post-operatively. With the stimulator alone, there was no analgesia. So some of these patients had single injection interscalene block afterwards. Next slide, please. Extended to foot surgery and looked at about 7 patients. A lot of these were feasibility studies that were done and noted that there was significant reduction of opioid use and pain scores as well. Next slide, please. This was one of the most important papers that was, I think, published in the world of peripheral nerve stimulation with regard to 60-day stimulation, in that in this study by Gilmore et al., they placed PNS leads in amputees with phantom limb pain. And these patients, a majority of them, even at 12 months, had a significant reduction in pain that lasted well past the end of treatment. Next slide, please. This is another study where they looked at postoperative pain and opioid consumption in patients that had electrical versus sham stimulation of different nerves and noticed a significant reduction in opioid consumption and average daily pain scores. Next slide, please. All in all, I think with regards to acute pain, it minimizes the need for opioids and associated side effects associated with them in the immediate postoperative period. The lack of motor weakness and lack of proprioception that might be seen with peripheral nerve stimulators is not there with these devices. It facilitates early rehabilitation. These devices are less clunky and they can be placed fairly far away from the target nerve to reduce the risk of damage, and the risk of infection is low. Next slide, please. There's a lack of surgical anesthesia with these. Those are the cons. It can take longer to insert and place peripheral nerve catheter. There's also risk of lead fracture and dislodgement. And I think one of the biggest concerns in using this in a more widespread manner is the lack of reimbursement and the MRI conditionality with retained lead fragments. And also, overall, there's also limited data. There's no head-to-head trials that compare PNS with peripheral nerve catheters, and most of these had been smaller feasibility studies. But it does pose an interesting question, and hopefully more research will be done in the area. Next slide. And then that's the end of my presentation, and I will table any questions for the end of this session. Thank you, Renee. Thank you, Liz.
Avner, thank you very much for the outstanding presentation. And I think we are moving forward to our last presentation of tonight's webinar, and this is presented from Dr. Kiran Patel. Like we mentioned earlier, she practices in New York. She is the program director of the Pain Medicine Fellowship of Hofstra University, and she will be talking about spinal, or SCS, dorsal column stimulation, and dorsal root ganglion stimulation. Kiran, welcome to the audience.
Wonderful. Thank you all. Can you see my screen here? I take that as a yes.
Yes, yes, looks good.
Okay. These are my disclosures. I'm a consultant for Abbott and some stimulation companies, Biotronic, Saluda, PNS, Mainstay, and Relievant. And spoiler alert, I will not be talking about off-label things tonight because we have so much to cover. But for anybody who's watching, feel free to reach out to me if you have any questions about off-label use of things. So spinal cord stimulation, we're going to follow the same theme of tonight, which is the indication, the approach, and the outcomes. So indications, right? You know, as my colleague said earlier tonight, you know, first and foremost, this has to be a patient who wants a device, right? And a patient who we have a sense of what their diagnosis is. And for any type of neuromodulation, we know that neuropathic pain conditions respond the best. And that is certainly something that you want to see that your patient has. We're talking about pain in the trunk or the extremities, either unilateral or bilateral, where conservative therapies haven't provided, you know, sufficient relief, and we've had, you know, a good run at some of these conservative therapies, and that, you know, we've ruled out structural disease, and that also we've ruled out any psychological barriers. You know, I always say, why do we do psych evals? It's one, to make sure there's no deep-seated anxiety or depression that's preventing our patients from progressing forward and quote unquote feeling better, but also to verify that they understand that there's a trial, and only if that trial meets their goals of care will they move ahead with a permanent implant when we're talking about spinal cord stimulation and dorsal root ganglion stimulation. So the FDA tells us the label indications for spinal cord stimulation is chronic intractable pain of the trunk and or limbs, including unilateral, bilateral pain. For those of you who have yet to do a peer-to-peer to get a prior authorization, this will eventually flow off your lips, and you will be able to recite this in your sleep. Namely, the most common conditions are failed back surgical syndrome, complex regional pain syndrome, both types 1 and types 2, otherwise known as causalgia, intractable low back pain and leg pain. And some of these etiologies might include radiculopathies, epidural fibrosis, arachnoiditis, degenerative disc, any patient who's had multiple back surgeries, and most notably, new indications, painful diabetic neuropathy, as well as non-surgical back pain. We'll talk briefly about some of the evidence, you know, in that area. So who are ideal and not so ideal candidates? Well, CRPS, we know this from the literature. We'll look at some of that in some subsequent slides. Cervical or lumbar persistent radiculopathies, ischemic pain, which is something that in the United States, we don't really address much with neuromodulation. But if you look at our European colleagues and others around the world, you'll see that there is a good amount of published studies regarding ischemic pain, both angina and peripheral, and as well as neuropathy. And who does not do so well? These are patients who have central pain, patients who may have pain after, you know, strokes, patients who have phantom limb pain historically have not done as well as CRPS patients, avulsion injuries, any patients with truncal pain or visceral pain, although we have made a lot of progress, historically do not respond as well. So the approach, first and foremost, you know, I say, you know, I grew up playing golf, and for any of you who are athletes and have played sports, you get used to setting up or doing, you know, playing your sport. For me, for approaching golf with pre-shot routine, you do every single thing the same way. And so, you know, when you do any procedure, any higher level intervention, you want to make sure that the patient is positioned properly. And that can vary from patient to patient, depending on their lordosis. You may use a bump to lessen the lumbar lordosis. You may actually have that bump higher up under, you know, their upper abdomen, depending on their abdominal protuberance. And you want to make sure that you're visualizing with your x-ray before you go ahead and prep and drape. Because once the drapes drop, it gets a little bit more complicated in terms of adjusting the patient's positioning. It really does make a huge difference, you know, because the first step you're going to do is you're going to identify where your entry spot is. So typically, if we're talking about thoracic stimulation for lower extremity or lower back, we're entering at L1, L2. And then we're talking about upper extremity, we're entering about C7T1, although you could enter in the lumbar space or high thoracic and then float the leads up. In general, we're suggesting, you know, and as you know, your first shot at neuromodulation, a paramedian interlaminar approach. When we get into dorsal root ganglion, we'll talk about some other approaches. But the thing you need to master during your fellowship is the approach to the epidural space. And so we call this, the contralateral approach. And so what we're doing, you would start at the pedicle, depending on the patient, depending on their AP diameter, how superficial their spine is or how deep it is, you're going to decide. And the more cases you do, you're going to have a better understanding. If it's a deeper spine, you're probably going to start a little bit further back on the pedicle, at the level below. If they are thinner, you probably will start a little bit higher on the pedicle at the level below. And so ideally you start with your needle just medial to the pedicle, and then you're guiding your needle toward into the interlaminar space. I tell my fellows to try to enter the epidural space if they're doing an SCS like they would be doing a DRG. So with that, my advice is to certainly get used to having your final needle entry into the epidural space be in the center of your interlaminar space, but also be in either the middle to higher superior aspect if you're doing a contralateral approach. If you're doing an ipsilateral approach, I would say you want it lower in the epidural space. And again, that's something we could talk about offline if people have more questions about that. So you're going to walk, once you gently touch the periosteum, because remember the periosteum is lined with C fibers. So if you're so happy with the 14 gauge needle and you bang down on the periosteum, the patient will have so much pain for the first few days of their trial that's going to be hard for them to differentiate, if the device is helping them. So my best advice is to actually go first with a spinal needle and to gently go down and touch the periosteum. Once you are at the periosteum that's just shy of the interlaminar border there, go ahead and deposit some local anesthetic. And then as you remove the spinal needle, continue to deposit local anesthetic along that track. Then wait before you proceed and then enter with your TUI needle. Your patient's going to be a lot more comfortable and have a better outcome during their trial. So again, once we are, we have our TUI needle, we've lightly touched the lamina, we're going to gently walk toward the interlaminar space and to that laminar border. And so at that point, once we're at the interlaminar border, then we're going to move over to our loss of resistance technique. In general, as you all know, probably at this point in your fellowships, you want to enter at an angle no greater than 45 degrees because we feel that the shallow angle definitely translates to being posterior in the epidural space when we enter. So the more shallow your angle of attack in general, it's going to allow you to steer the lead better and also for you to keep the lead in the posterior epidural space. There are exceptions to that based on certain patients' anatomy, but again, you want to start with patients that have simple anatomy for your first few cases. So loss of resistance with air can be done. You can also do it with saline. I personally prefer air. I have trainees, I have 5 fellows in our program, and it's really nice to kind of have that clarity of, what's CSF, if God forbid it happens, versus, saline versus air. But there is no right or wrong answer to that. It's just preference. And so we talk about where do we want the lead tips? Well, we say it's either 2 to 3 millimeters to the right or left of midline. And you want to essentially stay within the shadow of the spinous process. I think that's always a good term. If we're trying to cover the lower extremity or axial back, covering the bodies of T8 to T10 is a good goal there. In the upper extremity, we want to go from anywhere between the occiput to levels of C3 with your electrodes. And then you want to know that if your leads venture too far lateral, you're going to end up in the gutter, and you're going to end up with some nerve root stimulation. You might end up with some motor stimulation, which is not what the patients desire. And it's also, people often think that gutter stimulation or lateral stimulation is the same exact thing as dorsal root ganglion. It's actually very much not, and this has been studied, but that's a conversation for another evening. Similarly, if the leads are placed too low and they cover the conus, and remember, you want to look at your patient's MRI imaging ahead of time so you know where their conus is. It's going to vary. For some people, it's going to be at L1. Sometimes it's going to be on the lower side of L2. And if your leads are covering that, you're going to get a very unpredictable pattern. We know that the homunculus that we've seen, we talk about rather mapping the dorsal column. It changes when we see the most superficial fibers are the sacral fibers that are right at the conus. And in fact, we're making use of this with some of the work that's being done for the use of spinal cord stimulation for those who have been paralyzed or have spinal cord injury. So that's something to be aware of, and to always pay attention to where your patient's conus is. So when your imaging matters so much, not just to have the end plate of the inferior aspect sharpened up, but also to make sure that your spinous process is lined up directly between the pedicles. So you have a sense of what is anatomic midline, therefore you can approximate what might be physiologic midline. And so here in the cervical spine, it can get a little different. You have to be able to, you want your patient's neck to be positioned straight, but at the same time on your image, in order to differentiate, what is your anatomic midline, I think it's a good suggestion to isolate their odontoid process and then to follow their spinous processes down and then kind of draw a straight line there and use that as your anatomic midline. So in terms of, when you're steering the lead, I think, some of the cadaver labs that you're exposed to during the year are a great opportunity for this, obviously, as well as cases that you'll do and some of the simulators that are available now. But each manufacturer is different in terms of how much you rotate the stylet and how much the distal tip rotates. So each company is going to vary a little bit. And so I think, the best thing is to use pulsed fluoroscopy while you're first learning and to limit the amount of live that you do or to use it judiciously. So I always find that if I steer it, hold it in the direction and then advance it, that's a good place to start and a good way to get kind of acclimated to how a particular manufacturer's lead might steer. And again, what we're looking for is to have the leads in the posterior aspect of the epidural space. You can see on the right of your screen there, we're looking at lines which delineate the posterior aspect of the spinal canal and then obviously anterior. So when we talk about what's anterior, what's posterior, if your leads are up against the posterior body of the vertebral bodies there, then you are posterior, superior, you are anterior, and you're most likely going to get some type of motor stimulation. And you probably want to reposition your needle. You might want to even think of, if you didn't take the time or you weren't there when the patient got on the table, maybe you want to lessen their lumbar lordosis. Maybe that would help you. So some of these things need to be taken into consideration. Again, looking for that nice posterior placement. We can see here's a picture of a cervical. And then you gotta make sure that those trial leads stay in place. A great thing is something called the stay fix or a nephrostomy tube dressing can be used to really nicely adhere the leads. If you don't have access to that, suture is great, as well as a combination of Sterifix, Hypafix, or Tegaderms. My fellows know that Hypafix is if my practice was burning down, I would take the Hypafix and then make sure we all got out of the building, because it's probably the thing that we use the most in terms of making sure that our leads stay in place. What's also very important to know is that there have been several studies done which document that when a patient moves from being prone to being, upright, that the, leads will move anywhere from 1/2 to 1 full vertebral body when they assume that position. So I always take that in mind, that if I'm placing SCS leads, I'm gonna put them a little bit higher, knowing that likely either when they first get, go from prone to being upright, the leads are gonna move, or that when during the course of the trial that the leads may move down a little bit. So there are different techniques. You can do ipsilateral at at levels that are on the same side, or you could do two needles at the same level. A lot of it depends on the patient's anatomy or your comfort. I know I have some colleagues who prefer to just enter on the left side because they stand on the left side. So they do 2 adjacent levels. So some of the outcomes, some of the best research that has been published about spinal cord stimulation, done by Kumar and really Kemmler, looking at failed back surgical syndrome with Kumar's work, and then looking at CRPS with Kemmler. And so we know that for these therapies, efficacy was established, early by these individuals. And, that's kind of the basis of where the genesis in the field of neuromodulation really came from. That was followed up by obviously the doc, and also concomitantly with the work of Dr. North, and many other studies that have looked specifically deeper into failed back surgical syndrome, comparing it both to medical management and then comparing it to reoperation. and even a crossover study that was pretty interesting, done by Dr. North in '94. So we fast forward, right? Because there's so many studies that you as fellows or you as residents also need to know. And some of them, we're going to talk about some of the newer ones. The study that has been looking at burst DR and looking at axial back pain, distinct, which the preliminary data, 6-month data was published, showed, really compared patients who had conventional medical management compared to burst versus conventional medical management alone. We saw that at 6 months, 85.2% of the patients had significant back pain relief, which is 50% or more, versus only 7.1%, obviously, in conventional medical management. Their average pain reduction overall for the burst and the conventional medical management was 69.7. They had also 87.2% reduction or improvement rather in ODI, and then improvement in their pain catastrophizing scores. This data, I think they're going to be presenting 12-month data at NANS, which is in a few weeks, which hopefully we will see a lot of you at. Moving forward, another study you probably need to know is the Medtronic data, the DTM data, looking at the efficacy of DTM in diabetic neuropathy. This was 12 sites. They had 3-month and then 12-month data. They found that in the arms of the DTM, 84% responder rate compared to 51% responder rate in tonic. This is one of the studies that you should know if you have not read it yourself. Another one is obviously the HF10 data looking at painful diabetic neuropathy. And this was looking at patients who had the condition for greater than 12 months. They had failed gabapentin, pregabalin, had lower limb VAS score greater than 5, and were medically suitable. These are diabetic patients, so that's obviously a relevant concern. What they found is that the conventional medical management with HF10 had a 79% responder rate compared to only 5% at the conventional medical management arm. Again, a study that you should know. Now, if we look at, what is the good double-blind randomized control studies that are in our field? And there are very few, right? So at 24 months, the only randomized control trials that we have are the Senza process, which features the Medtronic, and then Promise, which is also a Medtronic study. That's the only 24-month data that we have that has been a randomized controlled trial. The caveat is that the most recently presented was looking at the efficacy of closed loop spinal cord stimulation, which was a look at 36-month data. And we'll look at this because this study was, not only was it a randomized control study, but it was a crossover. So after 24 months, the patients in the closed loop and open loop were given the option to just cross over. And then they were given the option to either stay in that or to flip back to their original therapy. And what was found is that, of those in the closed loop, their efficacy, their responder rate, those who had greater than 50% improvement in their VAS, was 83% at 36 months. In addition, we see that of those who were high responders, who had a greater than 80% improvement, 59%. So, our optimization of our outcomes are getting better as our technology is evolving, and we are having better designed studies. So some of this important studies to know are the ones that are highlighted here. There are several other ones. Feel free, if you want to send me an email, I can send you a quick and dirty list of the studies that you should know, because they're important to know because they have been pivots in the field and the development of neuromodulation, but they've also inspired other individuals to do further work. So that's why they're pivotal studies that we talk about. Going back to the Evoke trial here, not only did these patients have an improvement in their VAS, they also had improvements in quality of life, physical function, sleep, mood, and of the patients who had the closed loop, there was a 55% opioid reduction. So shifting over to dorsal root ganglion stimulation, again, we're going to follow through with our trajectory here with looking at the indications, the approach, and then some of the evidence. So the FDA labeling for DRG, and tonight we're going to keep it on label, is for those patients who have moderate to severe chronic intractable pain of the lower limbs, adults with complex regional pain syndrome, CRPS types 1 and types 2. And what's important, and what was actually amended in 2018 by the FDA, is that well, you can see printed there in blue that CRPS type 2 causalgia is defined as a painful condition arising from damage to a known nerve. And this nerve damage can result from traumatic or surgical nerve injury. And, the changes that we see in CRPS1 that are, need to meet the Budapest criteria, that does not apply for CRPS type 2 causalgia. And this is important because if we look at the incidence of CRPS types 1 and CRPS types 2, I often say CRPS type 1 is truly like the flamingo, and what's more common is causalgia, which is a lot of pigeons, right? I mean, because you could have, the best way to think of the definition of causalgia is if you can name a peripheral nerve that was injured during surgery or through a traumatic injury, that probably falls under CRPS types 2. And again, these patients may have characteristics that overlap with the characteristics of patients with CRPS type 1, some of those Budapest criteria, but they do not have to meet that criteria. And this is a point that is often kind of argued on a lot of the peer-to-peers I have to do for this therapy. But it's really important to know that the FDA made this distinction. And that is something that, we need to have our insurance payers and kind of honor. So again, if you can name the peripheral nerve, and it's either been damaged surgically or by an injury, that's CRPS types 2, also known as causalgia. And some of these included in this are those who have had hernia repair, knee surgery, ankle surgery, pelvic surgery, lower extremity amputations. And you can see, this data is actually from, I think, 2020. Our numbers are probably much higher than that at this point, but there's a lot of these patients that are around. So the approach. So the first and foremost, you got to know what your target is, right? People say like, oh, why do I need to do DRG? It's so complicated, and et cetera, et cetera. Well, it's a different neural target. And so when we apply an electrical field over this neural target, it behaves differently, right? And it's very distinct, right? So from patient to patient, it's very reproducible. So, sometimes we'll be doing a peripheral nerve stimulation case, and the patient's anatomy is a little different. And so it's not as reproducible. Here, if you're looking for a particular dermatome stimulation, from patient to patient, you're going to get pretty much a consistent response. There may be some variations if there's extra lumbar segments, but in general, the dorsal root ganglion is a collection of sensory cell bodies that's located directly under the pedicle, okay? So on an AP view, you can see we progress from the cartoon to the anatomical drawing to then the fluoroscopic view, and you can see there's the pedicle, and then you can see directly underneath it is where the DRG lies. Again, and very important to understand on a lateral view, the DRG lies high in the foramen and posterior for the most part there. So that's a very important distinction as well when you're verifying the placement of your leads, understanding where the DRG actually sits. This is a cartoon image of what our goal is here. So there is an epidural needle, a TUI needle, 14 gauge. And so we're inserting the TUI, and then through there, we're inserting a sheath. And then that sheath is allowing us to feed a lead that is positioned such that, there's 4 electrodes on this lead, such that electrodes 2 and 3 are centered directly underneath the pedicle. And that's really the optimal placement, and where most of your patients you're gonna want to stimulate in the center of underneath that pedicle. And so if your lead goes a little bit further, you may stimulate on lead electrodes, 1 and 2, or you may stimulate on electrodes 3 and 4, depending on how your final lead placement is. And then you can see in that cartoon image there, we are going to form some loops. Those strain loops, their purpose, there is a purpose to them. Their lead redundancy, that the first loop really needs, if it's going to do anything, it has to hug that pedicle. And we'll look at some fluoroscopic images of that. And then the second loop rather, is actually, its goal is to actually keep the lead high in the foramen, and it's actually to bump it up. So I have issue with this cartoon here, because that second loop should actually be flipped the other way and should be actually bumping up the DRG. Now, this is a cartoon image here of looking at the electrode, looking at a lateral view, and the DRG is the brown structure there, and you can see the lead on top of it. And what you see are those drawings there. Those are the actual intraforaminal ligaments. So when we're trying to tap and get the lead to go out, we're not trying to break anything. What we're literally trying to do, it's almost as if those intraforaminal ligaments are like the strings on a tennis racket, and we are literally just trying to slip through the openings there. So I want you to keep this visual image in mind next time you're doing a DRG trial. We're not trying to break anything. We're just trying to find that opening. And so that's why when the technique to do that is to twist the sheath and to tap the lead. So you're going to advance the lead while you're twisting the placement of the sheath so that you can try to test various openings to find those holes within those tennis rackets of the intraforaminal ligaments. So very important in this procedure is alignment of the C-arm, just like it is for any interventional spine procedure. We want to align the inferior end plate of the target vertebral body. I often say this. First thing, sharpen up the laminar space for where you're working to get the epidural access. Once you have the epidural access and you've confirmed that you're in the epidural space, then shift your C-arm so that the actual inferior end plate is then aligned. So first focus on your epidural access. Once you get epidural access at the level below, then resharpen your imaging at the targeted level. I always have my fellows do this. We actually will lay the needle on the patient's back and kind of map out our trajectory. We take a fluoro shot and we transfer that to the opposite screen so that we have that for reference. And then we do the same thing. We anesthetize the periosteum. It's obviously more important if it's a trial than if there say an implant under general anesthesia. But either way, we want to anesthetize the periosteum and then follow that trajectory. It's also a good way to kind of figure out your way around the anatomy before you're using a 14 gauge Tuohy needle. And then once you have your trajectory, you want to do the same thing. You want to enter the interlaminar space. Now, for tonight's conversation, we're going to focus most of our discussion here on the contralateral approach, which I think is the most basic approach. However, what is also on label is the ipsilateral technique. And we'll speak to that in a few moments. But when you are pursuing the contralateral technique, you want to enter the interlaminar space, certainly in the center, and then you want to enter either in the middle of the space to superior in the space. And the reason that is because you got to think about your next step. Your next step is that you're going to put your sheath and you want it to facilitate going out of the foramen very easily. And if you're doing the contralateral technique, middle to high in the in the space is going to allow you to do that. Now, if we're doing the ipsilateral technique, it's a little bit different. We're going to, sharpen up the end plates. Then once we have a nice AP view, we're going to then oblique to ipsilateral side about 5 to 10 degrees to really open up that interlaminar space. And once that's opened up, then what you're going to do is your goal is to actually insert the needle parallel to the spinous processes. And for that, I would actually want you to enter in the center, but low in the epidural space, because that will facilitate you coming out on the ipsilateral side much more easily. And this is a picture of that. And this is technique that has been published. And is also in the original ANS or St. Jude Abbott manual as well. So it's not a new thing. It's something that's been around for a long time. So the delivery sheath, this is what it looks like. It's a cartoon picture of it. And it is, you'll see that there is injection side port there. The only purpose of that is to really tell you what direction you are facing. The direction of the side port there is the direction of the curvature of the sheath. So when you're steering the sheath, you could take a fluoro and see, but you also have a sense of what direction you are just by looking at the side port. In addition, the way you want it to be set up, you want a very small amount, probably like about 1 to 2 millimeters of the lead exposed at the very tip. You don't want any of the electrodes exposed, but this will ensure that you're not creating a shearing effect as you're moving the sheath out of the foramen. And after you have positioned that, then you want to tighten up the hub, which is that spool at the end there. And what that does is it prevents the lead from moving, on its own in and out of the sheath. But once you're beginning to deploy the lead, then you're going to unlock that hub and then you're going to advance your lead. So first our epidural needle is in, and then we advance our sheath. And the goal of the sheath is to make contact with the inferior aspect of the pedicle. And you're going to really feel it kind of brush past the pedicle into the foramen. This can be different for different people. And that's why looking at pre-op imaging is really important to get a sense of what's going on with the foramen. Is it somebody who has, you know, some elements like a little bit of foraminal stenosis, or has inferior articular process from a level below that is significant, that might be prohibiting you from entering lower and you really have to stay high? Or is this somebody who actually has the opposite, has you know, some arthritis, and then you need to enter a little bit lower in the foramen? So look at your pre-op imaging. This is going to allow you to figure out what your strategy is going to be, and in particular if you encounter any difficulties. So once your sheath is there right underneath the pedicle and you're happy with the positioning, this is where you're going to, for those of you who are right hand dominant, you know, what I recommend is that you twist the sheath with your left hand and you're tapping the lead. And again, you're literally just trying to move the sheath and tap the lead to find the opening of those intraforaminal ligaments. And that's going to really allow you to most easily pass your lead. A lot of people, some of my colleagues, will not use a lead. They'll go straight with the guide wire. I think this technique, you know, gentle is best. And this can be done with the lead. And if you have a difficulty with the lead, then sub out the lead, meaning unlock the chain, unlock the lower lock, and then take out the lead, and then place your guide wire, and then try to tap with the guide wire because it's a bit more firm at its tip. But in general, I would say try to go with your lead. You know, give it a good go in terms of turning it, changing your angle, and then if you can, then go with your guide wire. And this is the ideal placement that we talk about. So again, there's 4 electrodes and labeled, you know, the most distal is 1. And the most proximal is 4. We want it positioned such that electrodes 2 and 3 are directly underneath the pedicle there. And once we then have done that, the next step is to create the strain loops. So first step, so you're happy with your lead. I always say give yourself a little bit extra, especially when you're first starting to do these cases, meaning although your electrodes 2 and 3 are directly underneath the pedicle, push the lead out a little bit further, because when you make the loop, it's going to pull it back in. So first step is to pull about 5 to 10 centimeters of the stylet out of the lead, so the lead is a little bit floppy. And then at that point, what I say is you want to pull your introducer, and you can see that radiopaque marker is the tip of the sheath, the introducer. You want to bring that about 2 millimeters outside the needle. Once you've done that, at that point, then the first step you could do 2 things. And again, I say gentle is best. The first step is just to see if you advance the lead once you have turned everything, you know, so when you enter, everything's facing the DRG. But then once you start to make your loop, you want to turn everything toward the patient's head. So that side port goes from facing the 3 o'clock position to the 12 o'clock position. Okay. And so once you're at the 12 o'clock position, then you want to try to feed lead. And if the lead goes, many times what it will do is just follow the nice contour of the medial border of the pedicle. And you can see in this fluoro image, it's a perfect example of what you want. You really want that first loop to hug the medial aspect of the pedicle, and that's what's going to help keep it in place. So how big do you make your loop? Well, you definitely don't need to go any higher than the height of the vertebral body. So you can see on this image here, we're right there at the top of the vertebral body. That's how we know it's a nice kind of fat loop, nicely hugging the pedicle. I'm very happy with that. So at this point, what we're going to then do is, again, bring the sheath back to 1 to 2 millimeters outside the needle. So you'll see that radiopaque marker right outside your needle. And then what you're going to do is turn everything back to the DRG. Okay. And at that point, we're going to start to make the second loop. And again, you want to pull out more of that stylet to make the lead more floppy. Gentle is always best. So if you can, just try to feed the lead. And if it flops down into that inferior space, perfect. Because again, you can start to see it's starting to bump it up and hold it up in the space. Now, sometimes the lead doesn't behave that way because there's scar tissue, because, you know, patients had surgery before, et cetera, et cetera. It's arthritic, older spine. And so sometimes what you have to do is, instead of just feeding the lead, you actually have to advance the sheath. The things that I'll tell you about this is that if you're doing anything around the conus, you want to be very careful. And I would always ask you to try to just advance the lead without advancing the sheath, because it's going to lead to happier patients afterward. Again, this is just some more details on how to do it. Now, this is what a lead looks like if it's properly placed on a lateral view. And it's pretty zoomed in, but what you can see there is the lead that's right in the middle of the foramen there. And you can see in front of it is the posterior border of the vertebral body. If you see that your electrodes are going into the vertebral body, if you're seeing that like more than 2 electrodes are into the vertebral body, then your leads are too anterior and you're going to need to replace that. You know, because you have to think about what electrodes you're actually going to stimulate on and then where they're positioned. But anything that's into the vertebral body, they're going to be too anterior for you to really program on. Last step, once you're happy with your positioning, you got loops in, and I always tell people this, you know, when you're first doing your implants, when you're doing your trials, you want, at the end of the day, you want at least 3 loops. I say when you're doing your implants, you want 3 loops and an anchor. So when you're making your loops, give yourself 4, because by the time you anchor, half of a loop will have come out. You can always take loops out, but you can't put loops back in. So always give yourself a little bit extra, knowing that right before you cinch down your anchor, you can always take some out. But if you're doing a trial, you know, the things that need to come out, the needle, the sheath, and the stylet. What I like to do first is I like to actually retract the sheath first, then the needle. I leave the stylet in because just in case I lose a little bit of loop, if the stylet is in there, sometimes I can just feed the lead and I will be able to kind of recreate a loop, and that will save me and allow me to keep that lead nicely in place. So let's look at some of the outcomes. You know, again, I'm going to keep this on label. There is a bunch of smaller studies that have been done, but I think, again, going back to the key studies that you need to know as a fellow and as a resident, you know, definitely among that is the ACURATE study. And this was an IDE study. So IDE studies are done for the labeling and for the indications. And so this was done for the safety and efficacy, looking at dorsal root ganglion stimulation compared to tonic spinal cord stimulation. There's 152 subjects, 76 receiving DRG, 76 receiving SCS. And these are patients who had chronic intractable complex regional pain syndrome of the lower extremities. And so, you know, they were given a trial. If they had an improvement in their VAS greater than 50%, they proceeded to implant, and they were followed out to 12 months. So what we found here is that almost all of the DRG patients achieved greater than 50% pain reduction, and their average pain reduction at 12 months was actually 81.4%. And at 12 months, 86% of these patients had persistent pain relief. So, you know, for me personally, seeing the types of outcomes with DRG that I have seen, you know, it's very different than spinal cord stimulation. The patients who come in with the trials, it's not a, well, it helped me, it kind of helped me, didn't help me. What I often see is that these patients are like, this changed my life, and I don't know where my pain went. And you know, it's a much more binary kind of trial process. That's what I find personally. So this is a very interesting read. It was a pooled analysis done of the ACURATE study, and it looked at, you know, the percentage of pain relief for various body parts, you know, broken down into leg pain, foot pain, back pain, and groin pain. And you can see that the range of relief is anywhere from, you know, 70 to 80%. And I think this is really important to know. And I think, as you know, we have some off-label discussions about new indications that we're looking at, I think it becomes important. So my advice to you as students of, you know, residents and fellows is to really become a student of neuromodulation and pain medicine that you can build on top of. And so understanding the key studies in neuromodulation are key, so that you can establish that foundation to then continue to acquire information. And so, you know, if you understand the mechanism and the theory behind and the outcomes of what has been done in your career, there's going to be new therapies that you're going to be able to lead forward into new directions. So thank you so much for the opportunity tonight, and I'm excited to take any questions.
Karen, thank you very much for your presentation. You're representing the excellent program from Hofstra Northwell, and I think we are good on time. We have one question in the Q&A feature, and I think we have time to answer that. I'll read it out loud. It's from Jack Leal. Have any of the presenters had experience placing multifidus muscle neurostimulators? If so, how have the outcomes been? Who are the ideal candidates? And where in your treatment algorithm for axial back pain does this treatment fall?
So I have had a good amount of experience with reactivate stimulators, and the outcomes are pretty amazing. So for those of you who are not familiar, reactivate is the trade name. It is a multifidus muscle neurostimulator. It is placed at the medial branches, L3. And so, we're looking to activate the multifidus muscle. And what happens, these are patients who have axial lower back pain who are not otherwise surgical candidates, meaning we've ruled out significant critical spinal stenosis, grade 2 or higher spondylolisthesis. These are patients who have significant evidence of multifidus compromise, where the multifidus muscle is, on physical exam, isn't firing, and we see atrophy on MRI. So not only will you see a fatty infiltration, which we all talk about, but you also will see the muscle girth is actually smaller. So you'll see the muscles are a little bit smaller, you'll see the fatty infiltration, and you'll see patients in their history say something very similar. They'll say, doctor, my back, sometimes I'm fine. Then I go to lift something and I'm not fine. Or I go to sit down in a certain chair and I can't sit in that chair and I can't predict it. They're not sure of their activities. And they have this cycle of back pain. And it really goes back to arthrogenic inhibition. It's the concept that if you have an overload injury, right, whether it's a disc or a facet, you get inactivation of the multifidus muscle. You actually get decreased neuronal firing of the multifidus muscle. Therefore, you get atrophy. So when you atrophy that muscle, it's not stabilizing the spine, and therefore you kind of get into this cycle. So the device is for patients who failed conventional physical therapy to work on stabilizing the multifidus muscle. And, it's hard to do. Physical therapy is hard to find, individualized care. A lot of our patients fall into this. And so it's patients who have axial back pain, structural spine surgery is not indicated. They have evidence of multifidus muscle atrophy. And, they understand that this is an implant. We don't do a trial. Now, that's for many people who are in pain. It's like, oh, I don't do a trial. I don't know how, I don't feel comfortable about it. You got to think about it. Our spine colleagues, they don't do a trial before they do spine surgery. So, this is a different type of therapy to introduce to your patient. And that's why patient selection is crucial. The 5-year data, is about to be presented at NANS in a few weeks. It's very exciting. We have never had 5-year data for any neuromodulatory therapy in our field. And the results that I see mimic that, where these patients, the more they use the device, because they got to use it twice a day for 30 minutes, the better they get and the stronger they get. Now, there are other therapies I put in place for axial back pain. And so there is an algorithm, but this is for patients who have signs of multifidus muscle atrophy, and don't have other significant signs. There are some patients who I treat otherwise with other forms of neuromodulation for axial back pain. And they may be patients who have multiple pain generators that may otherwise be palliative cases, right? Where they could, if they were younger, if they were healthier, they might be candidates for spine surgery, but unfortunately they're not, or they absolutely do not want spine surgery.
All right. Thank you very much for the explanation. And I think we are coming to the end of our webinar tonight about neuromodulation. And it is my pleasure on behalf of Asthma Pain Medicine and the APPD to thank you for joining us tonight. And the next Asthma Pain Medicine APPD Hot Topics webinar will take place on March 5. That's a Tuesday, March 5. And we will focus on minimally invasive spine interventions. We will talk about vertebral augmentation, that's kyphoplasty, vertebroplasty, and we will also talk about decompressions, including endoscopic approaches. We hope to see you then. Thank you very much and have a pleasant evening.